Welcome to Conversations on Healthcare. This week we welcome Beth Macy, award-winning journalist and author of Dopesick and the follow-up Raising Lazarus on America's deepening opioid crisis. Now, here are your hosts Mark Masselli and Margaret Flinter.
The opioid crisis and the serious missteps that caused it have been well documented by our guest. She painstakingly told the story from Big Pharma's office to the distressed Virginia mining town, and her acclaimed book, Dopesick, has been turned into an award-winning miniseries. It adds up to 7 million Americans suffering right now from opioid addiction.
And now, journalist and author Beth Macy is here to tell us about the next part of the story, recovery. Beth's new book, Raising Lazarus, is an account of what she calls the everyday heroes that are fighting on the front lines of the overdose crisis. And as she says, patients cannot recover if they're dead.
Beth, let me welcome you to Conversations on Healthcare.
Thanks for having me.
Yeah, it's great to see you. And, you really have dug into the subject of those you call treatment innovators for opioid addiction. And I'm wondering, what do we know about treatment and what's working best?
Well, we know that we have an 87% treatment gap in this country, and that means that only 13% of folks with SUD have managed to get care in the last year. And that's, if we were getting a 13% in school, we'd get failed out. We're failing. Yeah. And another thing that I have noticed, having spent not as much time as you all, but, the better part of 8 years working on 2 books about this, is that people die when they are facing barriers to care. Mm-hmm. And so when you have most rehabs in the nation still not allowing the gold standard of care, buprenorphine and methadone, that's a huge problem. And I have seen, parents remortgage their houses and all manner of things to send their children to exactly the kind of care that isn't serving them the best. And it's just tragic. So, and what is working, there's this huge group, it's probably the largest group according to SAMHSA, 40% of people with opioid use disorder that say they don't want to stop using, they think they can't stop using. And that's largely because they've been stigmatized, either by the criminal justice system or by the healthcare system. And so this approach known as harm reduction, this idea of going to them where they are, even if they're still in chaotic use, and treating them like a human being with a treatable medical condition, is basically the gateway into care. And that's what I learned from the last couple of years reporting on the new book.
Well, Beth, you have some compelling stories, and certainly you talk about resistance from law enforcement, but you also highlight a sheriff in Fairfax County, Virginia, who himself is organizing medication-assisted treatment, I believe, for individuals. If we know that works, what more can be done to provide such an approach on a broader scale?
Yeah, so we need to be scaling up what people like Sheriff Stacey Kincaid are doing. She was willing to take a political risk. She's an elective sheriff. And she said, hey, she had a lot of prodding from her local harm reduction group, but hey, let's work together with the Community Services Board, which is, the state-funded mental health and substance use disorder group. And we're going to do things differently. So we're going to screen every person that comes in to our jail for addiction. And if they're willing, we're going to put them on buprenorphine if they had opioid use disorder. We're going to partner with a harm reduction group to send peers into the jail and work with folks in their addiction on coming out with a reentry plan. And when they get out, we're going to physically, literally meet them at the moment of discharge and help them go to their next step, which we will have been prearranging. But as you can tell, that's so different from what typically happens. So a lot of new rules had to be written and rewritten. And a lot of the deputies didn't want to do it at first. We're going to have bupe in the jail when a lot of people here have been arrested for diverting bupe. And, they just didn't want to do it. And so train, bring in experts, give the stats, tell other stories of communities that are doing it. Oh, and we're going to bring in peers, by the way, all of whom are felons, into the jail and let them, give them badges. They were very resistant. And then those who just simply couldn't get it, and I don't think it was a lot of them, were let go. That's risk. That's courage. That's really, I think, being a treatment innovator. And, and there's examples all throughout the book of people who are managing to bridge healthcare and law enforcement. And, some of them are just having fantastic results.
And really with common sense solutions. I was thinking about the tobacco settlement and what a disaster that was for many of us who lived through that time, and how monies were diverted to everything but, tobacco education for young people and intervention strategies. And beginning this spring, local government agencies started receiving funds from the $26 billion opioid settlement. I'm just wondering, have we learned anything? Are they prepared to put those dollars to the best use? And do you think they have good plans and strategies to utilize those dollars?
I think some do. The week before the book came out in early August of this year, I met with all the county commissioners in North Carolina, which, as you know, is where a lot of the book takes place. A lot of the good things are taking place. They're sort of this is a state that hasn't passed the Medicaid expansion, is a right-leaning conservative state. And my thinking was, if they can get harm reduction here, you can do it anywhere, right? And how did they get over those cultural barriers? That's kind of how the book begins. And but I know from that meeting alone that about half of the 100 counties in North Carolina didn't really have a plan yet for what they were doing with the money. And if we don't have a plan, then what are the chances it's going to go to either something unrelated altogether, which is not supposed to go the way of the tobacco settlement. We know that less than 3% of the money actually went to prevent smoking and smoking-related diseases. But I was hoping that this book would come out at this time when communities are making these really important decisions. I mean, and I'm really hopeful, but also a little cynical, that the money will be swiped by people in power for, ginning up more votes, for appearing tough on crime, or what some people in the book call hug a thug, and that it'll go to incarceration first models and abstinence only models that we know don't work as well for OUD.
Well, Beth, it seems to me that one really important system in the United States is the federally qualified health center system. It cares for about 30 million people, 1,400 community health centers with about 14,000 sites. And I think what's unique about them is not just the access piece, but removing the stigma, because you can be going for your regular primary care, your dental visit, your behavioral health visit, or your visit to get medication-assisted treatment. I think the increase between 2016 and 2020 was over 300%. Is this an approach that you heard much about in doing your research and writing the book, or what more can the health centers be doing?
Yeah, absolutely. I think the FQHCs are, I think a lot of the money should come through them, because they are not, dependent on the whims of politics, in my opinion. I know they're run differently location by location, but the ones I've spent time in tend to be a little more progressive. And, I begin the book with a nurse practitioner who is he's worked all day at a FQHC doing mostly addiction and HIV care. And at night, he works for a harm reduction group in a rural part of North Carolina. His name's Tim Nolan, and he's meeting people where they are. He starts out passing out needles. He quickly realizes that he's tapped into this population. He calls them the unseen. That's that 40% I'm talking about that aren't in our systems of care. And he begins with hepatitis C, treats them, starts reaching more people, and then they come to the conclusion that they really need to offer low barrier care, low threshold care. And so he's going to them where they are, whether it's in a McDonald's parking lot that they've prearranged to meet. and he's getting them on buprenorphine if that's what they want. And he's called ahead, and through his FQHC, he's arranged discount pricing at one particular drugstore, and he wants them to know two things. And I think this is really the approach to getting that 40% back into systems of care. One is you can get better. Most Americans have given up on this population. Mm-hmm. And a lot of folks with OUD themselves don't think they can get better. So first we got to have hope. These medications are actually pretty efficacious. We know that. There's a lot of studies going back to the late 80s on how well they work. You can get better. And two, just don't disappear. And that's this idea that we're not going to kick you out if you have a relapse. We're going to increase your treatment, your counseling, your social supports. Maybe you need a higher dosage of buprenorphine. Mm-hmm. But we're not just going to shun you and kick you out because addiction is a chronic relapsing disease. We wouldn't do that for somebody with diabetes.
No, not at all. Beth, you said that your book was hopefully a primer for people to start thinking about plans for how they might utilize this money. But your book is also a clarion call to examine the laws and health policies that need to change to fully arrest this ongoing crisis. What policy changes do lawmakers and regulators need to look at? And certainly you've got state level and national level, but what are you focused in on?
Yeah, well, at the beginning of writing about this, I was kind of naive about how healthcare worked. I kept asking people, what should the federal magic wand be, But finally somebody said, medicine doesn't really run at the federal level. I mean, there can be certainly powers of the purse can be employed to, incentivize people to treat this population differently. And, I think the Biden administration is trying to do that. We have the first president on record who's used the phrase harm reduction, and is putting money behind it. But when I say locally, somebody pointed out in my research in rural North Carolina, he pointed out that the county sheriff is the highest elected law enforcement official in America. So they hold huge sway over the way folks with addiction are treated in the healthcare, in the court systems. And so I'm going to show you innovators that I think are figuring out how to do it, even in red non-Medicaid expansion states. So I think immediately of Judge Dwayne Sloan, who was in Eastern Tennessee, an elected judge, and he's a former tough on crime prosecutor. And he doesn't believe in letting his probationers be on MAT at the beginning. And then something happens. He and his wife adopt a baby that has NAS. They get to know the biological mother, and they really get to know her story. And they realize she just can't do it without this. And so he does a deep dive, self-assigned deep dive, and he looks into the data and he says, how can we not be allowing this? So he partners with this physician named Dr. Steve Lloyd. Now, Dr. Steve is the doctor that the Michael Keaton character is based on in the Dopesick show. He really got addicted himself to OxyContin. He really, eventually got into recovery and became a leader. And so Dr. Steve meets this judge and he volunteers to serve on his drug recovery court, not because it has to be him or anything, but because simply he wants the voice of the medical professional there to start to change the thinking among the whole recovery court team. And so in a couple of years, they start, really wrapping services around these folks. And they have reduced overdose deaths by 80% in the 4 counties that Judge Sloan serves. But, they had to really work against some negative thinking about it. And they had to convince people. And if you go to the drug court, which I have, it's not like a courtroom you've ever seen. Like Judge Sloan knows these patients. Dr. Steve's sitting there. He's weighing in on whether he thinks they're using the appropriate, prescription dosage. And at the end of every person reporting how they're doing this week, Judge Sloan comes out in the front and gives him a hug and tells him he's proud of him. Yeah. And, they've had a reduction in NAS cases. It's a huge reduction in property crime that's addiction related. And, then he can go back to his voters and say, look, like, we're really dealing with the problems here.
Well, Beth, this is one problem that's a national problem, right? No one state or region of the country owns it or is immune to it. But at the heart of it, you have to have somebody who's going to be willing to prescribe the treatment, the medication-assisted treatment. And I was surprised by a statistic that only 8% of physicians have done what is necessary to get the DEA license, or the waiver, as we tend to call it, to prescribe opioid use disorder treatment, buprenorphine, medication-assisted treatment, however we want to call it. And I'm curious what your thoughts are on that. Is it a reluctance on the part of medicine? And certainly nurse practitioners and physician assistants can also get the license, as you referred to earlier. Or is it that it's kind of unrealistic maybe for a single person to be treating it versus needing a team to make sure that they really can do it safely and effectively? What's your thoughts on that? What did you hear in your interviews?
Well, I heard a lot of stigma among healthcare providers, and this idea that they're very, very busy, and it's easier not to have the difficult patients. And I think, we don't want those kind of folks in our waiting room is something that really happens. Now, I was talking to the drug czar, Dr. Gupta, not long ago, and of that 8%, he said very few of even the 8% prescribe. So even those that not everybody that got the waiver takes advantage of it. We are still turning out young doctors who don't know how to identify addiction and treat it. I have some good friends who just finished Harvard Med, then did their residency, just took a 9-hour board exam. They're a married couple, Harvard Med, Brigham and Women's. And they took a 9-hour board exam, and there was exactly one question on addiction in that whole 9 hours. So we're pouring a lot of tax dollar money into the GMEs and the graduate medical education to turn out new doctors that can't help with the disease that took out 108,000 Americans. So the whole system really needs to be revamped. And I'm hopeful that if this MAT Act, which is currently in the Senate, gets passed, that will X the X waiver, the so-called X waiver, that will get rid of this, which is another huge barrier. If they didn't, you don't have to have a special waiver to prescribe OxyContin, for instance, or Percocet, but you do to prescribe the addiction that you got from OxyContin or Percocet. So I think that'll open it up. There's still these physician patient caps. People who've been prescribing can prescribe after they've done it for a year or two up to, I think, 275. Mm-hmm. And, these are barriers. And I think we've got to make the treatments easier to access than the dope, because the dope is out there and it's very easy to access. And fentanyl is in almost all of it now. I was in Baltimore last month, and a public health worker told me that fentanyl was selling for $1 a pill on the streets of Baltimore. And that's frightening.
Not to toot our own horn, but all of our providers are MAT providers. And the national program that Margaret set up for training nurse practitioners, it's a prerequisite for anyone going through the program. So very important. We encourage all the health centers out there and all the providers listening certainly to weigh in on this. Margaret was saying earlier about, it's a national problem, but there are some communities that are severely affected by this opioid crisis. And NIH reports that as many as 10% of newborns are affected by neonatal opioid withdrawal syndrome. Wow. What do we know about the treatment for these babies?
Well, I didn't get into that too much in the new book. I did bit in Dopesick. We know that, people will say addicted babies, they're not addicted, they're dependent on the medicines. And I'm sorry, but I'm not that is not top of mind for me right now. But we know it's a huge concern, and it has led to a 17 times increase in foster care. And, I write about Batesville, Indiana in the new book. And, even the foster care parents are getting their foster kids taken away from them. So we're going to be looking at just a tsunami if we don't go upstream from this.
Well, that is heartbreaking and certainly warrants all of our attention. And medication-assisted treatment is our best hope right now. But you've noted, I think, that there may be some room for more breakthroughs on the horizon. We've heard about a FDA-cleared, drug-free, non-surgical device that uses neuromodulation to help in the reduction of symptoms associated with opioid withdrawal. Any thoughts on these types of devices? Anything else coming down the research pathways that you think is promising?
I am, my real goal with this book was really to show people out in the communities that are scaling these barriers of getting treatment access. I am not as up to date on the new scientific drugs and research as I probably should be for this conversation. But, we have these low-hanging fruits of Xing the X waiver. Yeah. And then reaching this really hard to reach population of folks that simply aren't captured. And so I think harm reduction, this idea of going out and going to people where they are and really enveloping them in systems of care is where we've got to start. Yeah. And, I'm also a fan of safe consumption, which is very controversial. But again, it's anything that gets people into systems of care, whether it's a needle exchange, passing out fentanyl test strips, or even safe consumption, which, New York City right now is the only location has 2 sites, and I think plans for a few more, because that's a big political lift these days. So
it seems to be the third rail when we're talking about intervention strategies. We think about healthcare providers legally prescribing opioids to treat pain, and you hear all kinds of anecdotal stories about doctors holding back on prescribing opioids, even when they might be helpful. And certainly the DEA always looming large over practices. Are we headed in the opposite direction and too much of an overreaction?
Yeah, a lot of folks think so. And there has been some recent research showing that, people are being force tapered, people who are not misusing their medicines, who are not, every week needing a greater dosage. And there's a lot of anger among chronic pain patients at the CDC guideline that came out in 2016. I think they walked a little bit of that back. Mm-hmm. I mean, certainly opioids shouldn't be the first line of defense for somebody with a moderate injury or even a chronic injury. But there is this large group of folks that are already out there on stable dosages. And I hear from them a lot. They're really angry. They're really hurting. And I tried to address that in the new book just because I knew they felt so unheard. And, if there's an example in the book of a doctor getting arrested for overprescribing, and we know the DEA has really cracked down on that. Some doctors have gone to jail, but what about the other patients that are they're legitimate chronic pain patients? And so I try to parse out what's the best way to treat them. It's not to force taper them, because then they're just as vulnerable to going to the black market, where the whole illicit drug supply has been, poisoned with fentanyl, as somebody who's using heroin. So nuance is required in all of this, but America isn't always that great at nuance. So I think it has, come back maybe a little too far, and we just need more education about all of it.
Yeah. Well, it is a complicated issue, and you may have seen some polling that shows Democrats and interestingly to me, low-income Republicans are generally more open to paying more taxes to fund opioid treatment programs. I think awareness is actually pretty high in the country that people are dying. I don't know anyone who doesn't know someone who lost a kid or a parent or a friend. But the polling also shows that Republicans and Democrats do not support placing a clinic close to them in their community, kind of the old, NIMBY problem. So it's a public perception issue, but it's also a real barrier potentially to treatment. And in your visits to communities, what have you seen? And is that part of the drive towards integrating treatment into maybe more generic healthcare systems or primary care systems? What are your thoughts on that?
Yeah, I mean, so in Roanoke, here where I live, which is the largest city in the western half of Virginia, needle exchange finally became legal in 2017, I think. And it was a couple years before we actually got one open, because the law was initially written that the city council and the chief of police had to sign off on it. So finally, 2 years later, we get one in Roanoke. It's only the second one, and in the whole state. And then it gets closed by one little 3-minute story on the local CBS affiliate about needle litter. So it's that NIMBYism, it's that cave, citizens against virtually everything. And instead of sending a group of volunteers to fix the problem, let's just have a conversation. So what can we be doing better? You saw the same thing happen in Charleston, West Virginia, when they located their needle exchange at the public health department downtown across from their fancy mall that they were, proud of, and then needle litter. And then that really blew up. It became a huge political third rail. And you now have politicians there running on anti-harm reduction platforms, which is just shocking because the city has the nation's most concerning HIV outbreak. And we know that needle exchange is the evidence-based care. So the thing that Roanoke did and what Charleston did was going to people where they were, having mobile vans so they can't say it's, not my backyard, because it's all over the place. And that is, I think that's something that communities need to look at, because it is politically more palatable. Mm-hmm. And in the words of Judge Sloan, who I was talking about a little bit earlier, like when people are reluctant to start a new program like this, call it a pilot, just start doing it and then show the results 6 months later, and try to draw attention to this works. We did something new. The world didn't end. People got better treatment.
Good organizing strategy.
It is. Beth, one last question. You called on President Biden to end the ban on federal funding of syringes. If he's listening right now, we hope he is, at least on tape delay. How would you make the argument to him?
I would say, come visit some of the needle exchanges I've been to. Mm-hmm. People think they're these big, scary places. They look like preschool classrooms. There's inspirational sayings up on the wall. People can come and get food. They can get non-judgmental connections to care. And we know their number one expense is buying the syringes. We know that people who visit syringe exchanges are 5 times more likely eventually to enter treatment. And that's what we all want. And, I know he's read the research. I know he knows this. It's a political thing. And like Sheriff Kincaid did, that began our conversation in Fairfax County, we've got to have courage.
Great.
Well, thank you, Beth, for your incredible journalism that's brought so much insight and attention to the opioid addiction issue. And thank you to our audience for being here. You can learn more about conversations on healthcare and sign up for our email updates at chcradio.com. Beth, thank you again so much for joining us today.
Yeah.
Thank you for having me.
Yeah, and really shining a light on this issue. Very important. Thank you. We'll continue to follow your work.
Absolutely.
I appreciate it.
All right, ciao.
Bye-bye.
Bye.